Hello, my name is Jana Gortz-O'Brien. I use she, her pronouns. I'm an adolescent medicine physician, and today we're going to be talking about adolescent sexual health and taking an adolescent sexual health history, applying a reproductive justice lens. For those of you who are involved with our program or are interested in learning more, this is the prelude to an interview skills session that we do with youth chat educators, who are youth educators who develop sexual and reproductive health characters and play the roles of adolescents and young adults with healthcare providers and healthcare professionals in training to practice some of the skills we're going to talk about today. For a roadmap for today's session, we're going to start by talking about how to apply a reproductive justice lens in adolescent sexual health conversations. And I'm going to ask you to kind of reflect with me a little bit on that. I'll then discuss some of the elements of a sexual health history. I won't do this in a lot of detail today, but we'll talk a little bit about what kinds of questions might be important to ask in a setting where you're talking about sexual health with adolescents and young adults. Then we'll move on and we'll talk about 10 pearls for talking about sex with adolescents in an affirming and a strengths-based and trauma-informed manner. I do want to mention that a few things that we will not be doing. We will not be trying to convince any adolescents not to have sex, or not to get pregnant, or not to continue a pregnancy, or to continue a pregnancy at all. We don't do that. That is not aligned with the reproductive justice lens. It doesn't promote an adolescent's autonomy. Instead, we're going to talk about meeting young people where they are and arming them with the information and access to the resources they need to be able to have the sexual health that aligns with their goals and identities. I mentioned the term reproductive justice, so I want to start by defining that term. I'm going to use a definition that is from the Women of Color Reproductive Justice Collective called Sister Song. For those who are not familiar with Sister Song, I highly recommend taking a look at their website. There should be a QR code that pops up here. They define reproductive justice as the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. A reproductive justice approach is inherently strengths-based. It believes that all people, including young people and adolescents, have the knowledge and capacity to make decisions about their bodies that relate to them and their health and well-being. A reproductive justice approach is also youth-centered. It centers the needs, interests, and goals of a young person without imposing our own goals that we may have because of our professional lives, our cultural identities, and all of those other biases that we come to with conversations around sexual and reproductive health. A reproductive justice approach is also affirming of many different identities. This includes cultural and religious identities, but it also includes identities, gender and sexual identities as well. And then finally, it is trauma-informed. So it recognizes that trauma, especially trauma related to sexual health, is ubiquitous, and it uses a universal precautions approach to trauma-informed care as it relates to sexual and reproductive health. So I'll ask you for a little bit to just reflect with me in your own space, wherever you're watching this, and think to yourselves, okay, let's think about what reproductive justice means. Let's think about these principles of being strengths-based, youth-centered, identity-affirming, and trauma-informed. And I'm going to ask you to, if you can, in your mind, think of a few examples about how we might apply any of these lenses or all of these lenses in talking with teens about sex. And I'll pause there to give you some time to reflect. So now we'll go through some of the elements of a sexual health history. The goal here is not to go through every single element or every way that you might ask a question, but to get you thinking about what components there might be of a sexual and reproductive health history that you might be important to include for young people. So I'll ask you to start by thinking together with me. What are some important elements to ask about, especially during adolescence, as it relates to sexual and reproductive health? So I'll cover a few here. I'm going to start with the CDC's 5 Ps. So these come from the CDC, and they're a little bit adult-focused and a little bit more risk-oriented, but I do think they can represent a nice framework for setting up or organizing a sexual health history. The first P is partners. Asking about partners might be about sexual partners. Are you currently having sex of any kind, or have you ever had sex of any kind? I've learned that have you ever had sex is a more direct question to ask with young people, because sometimes they'll say, no, are you sexually active, or are you currently having sex, but then I'll say, when was the last time you had sex? Or have you ever had any kind of sex before, like oral or anal or vaginal sex? And they'll be like, oh yeah, but that was a month ago. I'm not sexually active now. That was just a month ago or 2 weeks ago. So adolescents who tend to be a little bit more concrete, it might be important to ask directly, have you ever had any kind of sex before? And then, are you currently having sex with anybody? Other elements of partners can ask directly about relationships, and that might be, are you in a relationship of any kind currently? Are you seeing anybody? And then not assuming that if they're not in a relationship, that means they're not having sex, or vice versa, that if they are in a relationship, that they are having sex. The second P is practices. Practices, again, can refer to the kinds of sex that they're having. So you might ask about, do you have oral sex, anal sex, or vaginal sex? What kinds of sex, what kind of things do you do together? You might also ask about how they meet partners here and what other kinds of things they do with their partners for fun, or to be intimate together, or to connect together. And then sometimes when it relates to partners, you might ask about how they meet their partners. It's important not to assume monogamy, and it's even if they are in a relationship. To ask more directly, is your relationship open or closed, or are you seeing anybody else, even if they say they're in a relationship? It's also important not to make an assumption that because they have partners that they are doing certain practices, or because they are doing certain practices assuming the genders of their partners. And the next P is for protection from STIs or STDs. And I usually ask directly, do you and your partners do anything to prevent STIs or infection? What do you know about that? And then I might ask more directly, what % of the time do you use condoms or other forms of barrier protection? Those can be things like external condoms, internal condoms, or dental dams for oral sex. And if not, if they say, oh, only 50% of the time, or not really much, we don't do that, I'll say, are there things that get in the way? Was that a decision you made together? Sometimes there could be a lot of pressure from one partner or another to not use barrier protection. It's important to know that if your patient is somebody who really wanted to use barrier protection, and then their partner said no, their partners say no, what got in the way there, and how can we promote that agency within the relationship and talk to them about consent and what that means to them? Past history of STIs is important too, and I often include that as for that fourth P is past history of STIs, and then I also will ask about past history of pregnancy here. And then the final and fifth P in the CDC's 5 Ps is pregnancy plans or plans for parenthood in the future. So again, I started with those because those are the kind of traditional, original 5 Ps from the CDC. In recent years, over the last decade, we've really seen some additional elements of the sexual history come to the forefront, and I think those are especially important for young people. Some have added a 6th P for pleasure. And for young people, we often forget this P, that pleasure is still an important part of why people have sex. It's the main reason why people have sex. It's for pleasure and for intimacy. And pleasure in sexual health, feeling connected with your partners, doing things that feel good, can actually lead to better and safer sex for young people. So asking them about how things went as it relates to, if they are sexually active, how things went as it relates to sex. Was it enjoyable for them? Were there things they wished had gone differently? Were there things that hurt? And then meeting those needs too. Hand in hand with pleasure comes consent. Consent is essential for pleasure, and consent is an important part of what makes a healthy sexual relationship for young people. I often will use the Fry's mnemonic to describe what consent means, and this is a key literacy task for young people to be able to navigate their sexual worlds. The Fry's mnemonic stands for freely given, reversible, informed, enthusiastic, and specific, meaning that every sexual encounter should adhere to those 5 elements: freely given, reversible, informed, enthusiastic, and specific. Finally, and again, this relates to pleasure and to partners like we talked about before, healthy relationships and asking about those as part of the sexual health conversations can be really important. Understanding the context of decisions that they were making around sexual and reproductive health, who those people are that they're having sex with. Do those relationships feel safe and supportive? Are they being treated with the respect and dignity that they deserve in those sexual relationships? Is the sexual relationship that they're having something that they enthusiastically want to be a part of? And is the sex they're having something that they enthusiastically want to be doing? There are some great resources out there that relate to healthy relationships. As this is a new topic for you or it feels uncomfortable, I really love loveisrespect.org. There is a great relationship hotline as well as some quizzes on there about whether or not a relationship is healthy. They have some great inclusive language there too. So those are some elements of a sexual history. Now I'm going to shift, and we're going to talk through 10 pearls for talking with adolescents about sex, rooting in a reproductive justice lens. So we're coming back to those things you might have reflected on earlier. So first and foremost, before talking about sex with adolescents, please do some reflection and do your own work. Understand that there is a long legacy and history of harm and trauma that has been unfortunately inflicted by the healthcare system on many communities, including Black and Brown communities, including Indigenous folks, as it relates to sexual health. And as a result, there is a lot of rightful mistrust by young people of the healthcare system. What might this look like? This might be overt and outright. They might say something like, I have no reason to trust you, why would I do this? But it also may be things like, I don't want to be on a IUD, it could sterilize me. And fear of sterilization is a very real thing that comes up for folks, especially in communities where they don't have a reason to trust the healthcare system because there's been harm in the past. I also encourage you to reflect on your own internal biases as it relates to sexual and reproductive health. What biases do we carry individually as healthcare professionals regarding what sex looks like, what kinds of sex are okay, regarding gender and sexuality, or regarding adolescent pregnancy, for example? What are your own biases? Do you think teens can become pregnant? Do you think they could be good parents? Or do you carry some biases and stigma around adolescent parenthood? And finally, with doing our own work, this means recognizing that young people can make good decisions about their health and that they're able to, especially when armed with the information and knowledge and support that they need to be able to make those decisions. And autonomy and promotion of access are really a pillar of reproductive justice lens. Okay, tip number 2, please promote agency and autonomy. Here are some examples about how you might do that. The first is start with the young person's reproductive health goals. So they might come in and they might say, I want to be put on birth control. And you might say, what are your goals for that? What does that look like for you? What are your goals for your birth control? If they don't come in asking about birth control or asking about pregnancy prevention, but you're having a conversation around sexual health, you might even start more broad or a few steps back and say, what are your own goals for your reproductive health, for your family in the future? Are children something that you want in the future? What might that look like for you? Are you planning on becoming a parent in the next year? Those goals can be really important to know. Many adolescent pregnancies that do occur are planned, so it behooves us to ask directly about what the adolescent's own goals are and meet them where they're at. Another way to promote agency and autonomy is that right to pass. And this was covered in a different webinar, but what this means is that when we're introducing the concept of talking about sexual health, we reassure confidentiality. We reassure them that things that we talk about related to sexual health will stay between us. And then I also pair that with, and just because I ask a question doesn't mean you have to answer them, so this is the right to pass. So just because a doctor or a healthcare provider asks you a question about your relationship, your sexual health, or your health in general, doesn't mean that you actually have to answer it. You can always say pass. This is modeling boundary setting and consent, and it also is promoting autonomy and agency. And then reinforcing that the decisions are in their hands, that they have the right to decide when it relates to sexual health, when it relates to the kinds of sex that they have, when it relates to the kind of health care they receive as it relates to sex, as it relates to what they might want to do if they were to find out that they were pregnant, and letting them know that they have choices that they can make and that we're here to support them in those choices and arm them with the resources that they need and the knowledge they need to be able to make decisions that make sense to them and align with their values and goals. Tip number 3, protect their privacy. This means letting them know that they have a right to privacy. Again, that confidentiality assurance is important before embarking on conversations around sexual health. Providing time alone. For any well child care or any primary care visit, adolescents really should be offered time alone. And specifically when we're having conversations around sexual and reproductive health, gender, sexuality, puberty, we really should be asking about menstrual management. We should be offering to talk with all adolescents on their own, starting at a young age, at around 11 or 12, we can offer that, but by 13, doing it pretty consistently. We should be doing this every time. And then within that protect privacy rights, also looking at your own systems and seeing where breaches in confidentiality may occur. Many of us are operating in systems where we say that a young person has a right to privacy, but we send a bill home if they access a certain medication for their sexual and reproductive health. So really working within your systems to make sure that those bills don't get sent home or that there's another way to help get them those options if they need them. This also includes looking at our electronic health record systems and making sure that those health records really do protect the privacy of young people. Tip number 4, affirming identities. So we talked about one pillar of care being identity affirming care. This can look like sharing your pronouns and asking for theirs, not dead naming, and creating healthcare systems and electronic health records that don't dead name either. This includes working with all of your staff on your team, the whole interdisciplinary team, to make sure that we're using the patient's preferred name and chosen name. Responding non-judgmentally when they share something that they're interested in, something that they're doing sexually, part of their gender or sexuality. Responding with non-judgment and affirmation. Responding in a way that is shame-free and blame-free. And then finally, with one key way to affirm identities is to mind our own heteronormativity in the way we ask questions. So asking questions in a way that is gender neutral or gender affirming. Not asking questions like, do you have a boyfriend? Assuming that somebody who might be assigned female at birth or present femme has a boyfriend or vice versa. So again, we're minding our assumptions. And having conversations around gender and sexuality, if a young person seems confused or has questions, I will often use images like the gender unicorn to talk about this, and you can check out our talk tool on gender and sexuality to learn more about that. And then again, I mentioned this earlier, please do not make assumptions that sexual and gender identity are necessarily equate with the young person's sexual practices. So a person assigned female at birth who is a lesbian might still have had sex with men at times in their lives, and just because somebody identifies one way does not mean that they always have sexual practices that align with that identity. For more great resources on gender and sexuality, I use the Trevor Project fairly often. The Human Rights Campaign's Coming Out Handbook is linked directly there, and there are some great resources for LGBTQ+ youth available through the Trevor Project as well. Tip number 5, asking for permission. Again, this is another way to promote agency. This means asking for permission before starting the conversation around sexual and reproductive health in the first place. This also can mean asking for permission before difficult topics. Is it all right if I ask you a little bit more about that? It seems like that might be a hard topic for you. And then finally, before sharing advice. So they might have shared a whole bunch of things around sexual and reproductive health, and then you might say, hey, is it okay if I talk to you a little bit about ways that we might be able to prevent pregnancy, like birth control? And they might say, no, I'm not interested in birth control, I don't want to talk about that. So please ask permission and then heed their advice if they say no. Again, we're modeling boundary setting and consent. Number 6, lead with the most effective options when it comes to birth control, options counseling, gender, sexuality that align with their goals, identities, and interests. So again, if we start off with their goals and their identities and their interests and what they want to learn, then we can really tailor our counseling to meet those needs. A classic example is starting with a young person's birth control goals, if that's what they want to start with and talk about, and then counseling based on those goals. For conversations around sexual health, especially those related to contraception, it can be really helpful to use a written guide or menu for the conversation. I frequently use bedsider.org, which is a really youth-friendly website that is fantastic with a lot of great images. For people who are more visual learners as opposed to more auditory learners, it can be really helpful to have a visual aid that's either written or in front of them on a screen. And it's modeling, showing them where to look if they have more questions about their decision or about what they want to do next. The Reproductive Health Access Project also has some great written resources that can be really, really useful and helpful in guiding many conversations, including birth control, emergency contraception, abortion, miscarriage management, and along with clinical guides too. Tip number 8, use your online resources to make sure you're providing evidence-based care. The care regarding what kinds of birth controls are safe in the context of certain medical conditions is an evolving landscape. The best practice for treating STIs is an evolving landscape. Please use the existing online resources and have those at your fingertips. The things that come to mind are the Contraception U.S. Medical Eligibility Criteria app, pictured here, where you can look at point of care in the moment if you're a healthcare provider prescribing birth control to know whether or not a young person with a certain condition can access that method safely. Another example is the CDC's STI treatment guidelines. There's a great app for that as well, and that's a great way to make sure that you're staying up to date and that you're treating with the most effective current regimen. As an example, previously chlamydia was treated with azithromycin, a single dose, and is now shifted to doxycycline twice daily for 7 days. If you weren't using the app and you weren't following the literature, you might miss that and treat with a potentially older regimen. Azithromycin is still an alternative option, but doxycycline is the first line for chlamydia now for non-pregnant adolescents. Number 9 is no missed opportunities. So this tip means that when a young person is there with you, to not miss opportunities to provide things like recommended STI testing and screening, such as gonorrhea or chlamydia testing annually for adolescents, HIV screening for folks over the age of 16 and older, and hepatitis C screening for those who are older than 18. It also involves not missing opportunities to provide condoms and distribute condoms, to talk about HIV PrEP and PEP, for which anyone who has had a previous bacterial STI or anyone who is interested in PrEP or PEP is eligible for, and not missing opportunities to provide emergency contraception. Remember that if you're talking about sexual health with young people, you can ask, have you had any unprotected sex in the last 5 days? And you can provide them with a form of emergency contraception that works for up to 5 days after, such as ulipristal acetate or Plan B levonorgestrel, which works for up to 3 to 5 days after, depending on who you read. So again, not missing opportunities. And then finally, using written websites and guides can be really helpful, and online resources can be really helpful. And finally, I'll close with a 10th tip, and that is apply a trauma-informed approach with everyone. When I talk about trauma-informed care, I mean starting with an approach that supports and fosters resilience, builds trusting relationships, promotes psychological and physical safety, acknowledges the intersecting identities of a young person, avoids re-traumatization, which can be particularly difficult when we're doing sensitive exams like pelvic exams. It's an approach that's collaborative and an approach that promotes agency. Thank you all so much for listening. That concludes our overview of applying a reproductive justice lens to talking about sexual reproductive health among young people. This is not meant to be a comprehensive overview of all things related to sexual health, but it is meant to provide a primer for sexual reproductive health if you're working with young people and you're trying to really apply those reproductive justice frameworks. Thank you all for your attention, and please reach out with any questions. And for those joining us for interview skills or who are interested in interview skills with the Youth Chat program, please reach out.
About the Center for Healthy Youth Development. So our center was formerly known as the Healthy Youth Development Prevention Research Center until 2024, when we rebranded following the conclusion of CDC funding. And our Healthy Youth Development Center has an interdisciplinary team of researchers, trainers, and evaluators that are specializing in community organizations and state agencies and working with local groups. And we are based in the Department of Pediatrics at the University of Minnesota Medical School. And you can see all the ways to get in touch with us on the bottom of the page there. We very much value your feedback about this presentation series, so we'd really like you to take a moment to just complete our short survey. You can access it by using the QR code there on your screen, and there's also a link for you to access the survey that way. We would like to thank the Minnesota Department of Health's Child and Teen Checkup Program for the funding for this presentation.